to move on to introduce the first speaker, who is Stephen Laureys, a world expert in coma, and he's a clinical neurologist, a neuroscience researcher, world expert in vegetative states and coma states, and has also been studying meditation. And so the title of this session is Detecting Consciousness, and he'll be talking about detecting consciousness in, I think, in coma patients and also in meditative patients. And he is associated with University of Liège in Belgium, Harvard, and he recently moved to the Cerveau Brain Research Institute in Quebec, Canada. So please, a warm welcome for a really cool guy, Stephen Laureys.
Thanks, Stuart. Wonderful to be here. Can you hear me? Yes. So, we're all here because our passion is understanding consciousness. It's a challenge to define. So, how do we deal with this as physicians? Well, with the teams in Belgium, Canada, we are first of all looking at patients with severe brain damage after a traumatic injury or a hemorrhage, or cardiac arrest survivors, coma and related states, and use all possible machines, MRI scanners, PET scanners, EEG, TMS, to try and capture brain activity and compare that with what we see in pharmacological coma or anesthesia, and what we see in physiological changes of consciousness, such as sleep and meditation, hypnosis. I started my career over 30 years ago as a young physician interested in perception, thoughts, emotions, and doing surgery on rats, studying neuropathic pain. And it was quite frustrating because, of course, the rat couldn't share what truly was the experience when I was applying noxious stimuli. So that is the challenge, I think, of all speakers today. How can we say meaningful things about this personal first-person experience we call consciousness? So I'm gonna not talk about what is it like to be an animal, a bat, but keep it to humans. And you see here, I've got a wonderful guinea pig, my little son, Louis, the youngest of 5. We can give him a big applause. It's a tough job. It's not his first time. Actually, we gave a TEDx together. I'm not sure he remembers that because he was very, very young, talking about the emergence of consciousness in newborns, and we will hear more about that by experts today. And also about the challenge to say meaningful things in non-human animals. Again, we can't communicate, so it's something I know from my frustration as a neurologist working with coma and related states. So, the question is Louis conscious? And it's a tough question where, first of all, we have no definition of consciousness. We disagree what it really means. And yet at the bedside, if I see people at emergency, intensive care, rehab, how do I deal with that? We will reduce the complexity of consciousness to 2 main dimensions. First of all, that is Louis' level of consciousness, wakefulness, which is quite straightforward for me to measure, to capture. It's something we experience every night when we fall asleep. We look unconscious from the outside, but maybe we are in REM sleep, dreaming. So already we see the challenge. But so when confronted with coma patients, by definition, their level of consciousness, wakefulness is very low. They would have their eyes closed. Even when I stimulate them, auditory or noxious stimulation, they will not open the eyes. Very good. Similar to general anesthesia, pharmacological coma. Now, in the 70s, it was clear that some of these patients in coma, where wakefulness is damaged, hence the content of awareness is impaired, some opened the eyes. So they awakened, but only showed reflex automatic motor behavior. That was called persistent vegetative state. I don't like the term. We're not going to compare humans with vegetables. So now we refer to these patients as unresponsive wakefulness syndrome, because that's what we see. They're not responding to simple commands. And it was clear that some of these patients actually were sometimes a little bit conscious. That was coined minimally conscious state. This is really a challenge for us to say meaningful things about awareness in these people. We subcategorize that in MCS minus, which are patients who would show non-reflex behavior. Like if I would show a mirror, he would track with the eyes. We say this is the first sign of emergence. Or if, I will not do it again, we apply painful stimulation, he would push me away. Or if I would, there would be something emotionally meaningful, like the patient's family, there would be a specific reaction. Or I would tell a joke, he would smile. It's not just a reflex. This is the first sign, but that's all we got. MCS mind is the next step, MCS plus, which is passing the real awareness test, which is I ask the patient a question, Louis, raise your left arm. Wonderful. We trained this. It's okay, I will go with that. We trained the right arm, so my bad. Now the problem is, he passed the awareness test, which is obviously quite limited than the same my colleagues in ancient Egypt used, right? If I ask Louis, move your right arm, and he is not moving, did I really prove he is unaware? Maybe he's deaf, he's not hearing. Maybe he wants to move, but after a traumatic injury in peripheral nerves or spinal cord or motor cortex, his brain is no longer connected to the muscles. He is paralyzed. He can't move the muscles. So then I'm in trouble, right? The most extreme example is locked-in syndrome patients, where there's a lesion in the brainstem. The brain is intact. These people, they have thoughts and perceptions and emotions, but unable to share them, except by little movements of the eye. So Louis to say, yes, you can look up, to say, no, you can look down. This is it. Is your name Louis? Yeah. You should look up. So very, very challenging and a good example of how careful we should be. And that's why we developed, with our colleagues in Cambridge, the motor paradigm that's been shown by many other teams since, where we ask the same question, like, Louis, move your arm, imagine to move, to play tennis. But I'm not looking at his limbs, I'm looking at his motor cortex activity in an fMRI scanner. And so we've shown that some of these patients we thought were completely unaware, so-called vegetative unresponsive wakefulness syndrome, sent to us from all over Europe to the center in Liège, put them in the machine, ask them, imagine to play tennis, their motor cortex activates, and then we can decode that. We have another question, imagine to walk around in your house, activating hippocampus, and then the computer tells us, okay, this activation means yes, he's doing the motor imagery, and we ask questions, permitting us, first of all, to show, well, some of these patients actually hear, understand, and do what we ask them if we measure their brain activity, and next we could communicate with them. We also have now cheaper EEG devices, brain-computer interfaces, basically doing the same thing. So this was a big breakthrough in our measurement of consciousness, not so much in the next challenge, where I don't speak as a physician, but as a neuroscientist. How can I truly propose an explanatory theory of consciousness? And we'll come to that later. Louis, you were great. Thank you. Big applause. You are conscious. So in the, I think, community, there are big polarized views. For most neuroscientists, consciousness is seen as an emergent property of the collective behavior of those thalamocortical loops, global workspace, integrated information theory. And then there is the view that maybe consciousness can exist independently of the brain. I think sometimes near-death experiences, and we study them for over a decade now, is sometimes seen as proof of this non-local, cosmic, some other form where the brain would be more like a transmitter. How can we, again, translate that to clinical reality? When we started in the 90s, first of all, the study of consciousness was kind of taboo, which I think is a very bad thing. Also here, you'll hear a lot about the importance of quantum mechanics to understand consciousness. It's a very challenging field, but it definitely is not a good idea if we would start to apply auto-censorship. It's a very challenging topic, and we've suffered from behaviorism after Freud and Jung, William James. We said it's too complicated. We were just going to look what's going in, what's coming out with people like Skinner, Pavlov, and we're still, definitely when I started, kind of suffering from that. So we used positron emission tomography in the 90s. The brain is using a lot of energy, more than any other organ in your body right now for its weight. We inject radioactive glucose, and we can see those billions of neurons using a lot of energy. If we then look at brain death, which is the neurological definition of death, next to the old heart and lung criteria, we see the empty skull sign. So there's only some activity in the skin surrounding the skull, but none in these billions of neurons. So this is very important. Brain death is death, and if we have the diagnosis correctly, no patient since the 50s, 60s, when we have these criteria and a new machine called the artificial respirator that created a new medical discipline, intensive care, no patient ever came back to tell what it was like, recovered consciousness. And that is different from some people with cardiac arrest who do survive. And when we study them, they have a very severe, massive global reduction in brain activity, about 50%, but it's not zero. And it is in these cases that sometimes I hear patients telling me, whoa, I just experienced the most amazing thing. I felt amazingly good, a sense of well-being. I saw this light. I saw myself. So we are trying to understand these extraordinary phenomena that, again, maybe we didn't take seriously enough for too long, and I believe we can learn from those near-death experiences, and we're trying to understand, well, is the etiology, the cause of the coma. If we take people with hypoxic damage or those where there's no hypoxic damage, is there a difference? Because for some, this is an hallucination that we can just explain by lack of oxygen. It turns out that the stories are very similar. So we're not there yet. And also the notion that all of these experiences, and we have many hundreds, are pleasant seems not to be the case. We also collaborate with teams in Russia where in our cohort, the vast majority are positive. This is the 9 out of 10 most frequent feature, as you can see here. There, it seems that like half of them are very negative encounters with devil, being in hell. We also compared and published just one study here, how it maybe shows similarities with people who take psychedelics. So we have many, many drugs where we know on what neuro receptors they work, and compare it with near-death experiences, and it seems that DMT and ketamine are very closely related to the story we hear from people with cardiac arrest or other causes of NDE, and we can discuss that. So coming back to the people who recover from coma and looking at their brain activity as compared to normal, I mentioned brain death, empty skull sign. What we see in patients or in coma is a massive global reduction, similar to what we see in deep sleep. And as said, in REM sleep, there is something paradoxical. We have this dreaming activity, and the brain metabolic activity is very similar to waking. General anesthesia, we give a drug, patient is no longer answering simple commands, is in pharmacological coma. We stop the drug, the brain recovers. So it seems here that there could be a global threshold. If overall brain activity is very low, we lose consciousness. What I think we learned from pathological coma is that those people with coma and vegetative unresponsive wakefulness, despite the massive global reduction when consciousness is lost, when we look at those who recover, we don't see a full return of overall brain activity. In other words, you don't need the whole brain for you to be aware of yourself and your environment. So we've been studying patients in these conditions for decades now, using artificial intelligence to help us reduce the uncertainty with regard to the diagnosis, the prognosis, helping us to develop new therapeutic tools. But to summarize, it seems to be the case that when you are comatose or when you're awake but unaware, you have this dysfunction in a widespread frontoparietal network. Both hemispheres, frontal, temporoparietal, convexity, and also in the midline. And we see a similar neural signature of global neuronal workspace dysfunction in complex partial seizures, patients who for a couple of minutes are showing automatic behavior but no response to command, or absent seizures where they're just off for a moment, or sleepwalkers who in slow wave sleep suddenly stand up, start moving around, but again do not answer simple commands. Within this network, we could show that using EEG, event-related potentials to, in this case, auditory stimuli, what seems to be critical is how these parts of the brain interact with each other. Using techniques like dynamic causal interaction, you can look at the directionality of these interactions. So for example, here with Melanie Bowley, who's also in this conference when she was doing her PhD in Liège, now she's a professor in Madison, Wisconsin, she showed that for people who are consciously aware of these auditory stimuli, there is a top-down feedback connection from these higher order awareness networks to the auditory primary, secondary areas, who are more like necessary but not sufficient. They're like slave systems. So we don't see that top-down interaction in people who are in coma, anesthetized, or in unresponsive wakefulness, and this is now being applied at the single subject level in intensive care. So basically, we have all these tools and measurements to try and detect consciousness in people who are in coma and related states, and helping clinicians, of course, to make the important decision about neuro-rehab or also end-of-life decisions. So you see people who would have a massive global dysfunction in unresponsive wakefulness, and some of them at the bedside fail to show signs of awareness. We just tested in Louis, but when we do the neuroimaging, we see there is more activity going on. We call them MCS star. There is a dissociation between cognition and what we observed in terms of motor activity. This is minimally conscious state, there is minimal activity, and these are the healthy controls and the locked-in syndrome patients. And then we also look at brain connectivity, because that's the power of the brain. It's not just these billions of neurons is the thousands of billions of brain in connections, synapses, and how that activity changes all the time. And again, when we look at connectivity, we have people with intermediate activity who are brain-wise minimally conscious. We also worked with Marcello Massimini from Milano and Giulio Tononi, and you know his integrated information theory, where we can now look at the brain's reactivity to a perturbation. So we take a very strong magnet, this is called TMS, transcranial magnetic stimulation. Simultaneously, we measure the EEG, and the complexity of that magnetic shock perturbation tells us something about the brain's capacity for conscious awareness. So we tested many, many healthy volunteers, people who were in deep sleep, people who we put under general anesthesia, and we saw that if one captures that complexity of the perturbation in what we call the perturbational complexity index from 0 to 1, if you are below 0.3, people were unconscious. And this is also what we saw in coma, unresponsive wakefulness, and this is now very useful to help, again, clinicians. And this works even in people who are completely paralyzed and who are not understanding language, because what I was doing with Louis depended on his capacity. There's not just hearing impairment, it's also, is he understanding language, or even, is he willing to answer my question? I remember a woman I saw, and she recovered from coma, telling me, well, Dr. Laureys, I remember you asking me, squeeze my hand, look up. I just didn't see any reason why I would do that. So this form of akinetic mutism, form of minimally conscious state, of course, is a challenge for us. And this test works, whatever you like to answer or not, you're paralyzed or not, you're having trouble to understand language. This has been shown to be very useful. So we used it in people who were comatose, cross-validated it with anesthesia. We also studied people who are experts in mind control, Buddhist monks. This is Matthieu Ricard, translator of the Dalai Lama. He came to the lab, super guinea pig. We put him in all the machines, and he's the only one with these other expert meditators who's able to change the reactivity of the brain when stimulated with this TMS pulse. Coming to anesthesia, pharmacological coma, a number of studies using a number of drugs, always coming down to this impairment of the higher order global neuronal workspace when they are knocked out by the anesthetic. And if we stimulate them, they would still activate sensory areas. Like you see here, people who were studied by fMRI, wakefulness, mild sedation, unresponsiveness, and then recovery, you see that like visual areas here or auditory areas still show some activity. In other words, they're necessary but do not seem to be sufficient. Where it really happens for you to have an experience of your outer world and inner world seems to be in those frontoparietal areas, where we propose to subcategorize them, and we see that the areas in red, so the convexity, seems to be critical for you to have conscious awareness of your environment. What you see and hear right now seems to depend on that. Whereas in blue, that midline core overlapping what we call the default mode activity, because it's active all the time. It permits us to think, and the brain can't help it. It's thinking. You right now, you're listening to me sometimes, but you're also thinking about things you need to do the rest of the day, what happened yesterday. And so that kind of mental imagery that permits us to have autobiographic memory, to anticipate what's going to happen, critically depend on those areas in blue, mesiofrontal, anterior cingulate, precuneus, posterior cingulate. And we challenged that hypothesis in a number of studies. This is one where we just put volunteers in the machine, in the fMRI machine. There's no task, they're just laying there, but they hear a beep once in a while, and then they let us know, well, before the beep, I was more externally aware of the sound of the scanner, whatever, or more internally thinking about, you know, I need to do my whatever, answer an email, write a paper. And so it seems to be the case that the external awareness scores correlate indeed with those areas in red, internal with that midline core. And they seem to anti-correlate. So when one goes up, the other goes down. And in hypnosis, we see we can push them, and meditation, and have more focus on one or the other. So that was very useful to us, again, to cross-validate these. We also use this to predict. This is a study where Melanie Bowley, again, old study now, in Liège, showed that if we apply a laser and make the intensity such that about half of the time you wouldn't notice it, when we are monitoring the activity in those two networks, we could predict what people would say. So if the external, so sensory awareness network was high, they would indeed, for this limit threshold laser stimulus, say, I perceived it. When the internal, like when they were daydreaming more, was high, they would just miss it. Also regarding to internal awareness, we've been studying patients' self-reflection with the mirror that we also use at the bedside, patient's own name, and the correlation with brain activity. So all of this is now being used in hundreds of patients over different expert centers all over the world, and it is useful clinically because about 1/3 of patients, it shows that there is something that we, even with the best clinical assessment, could miss. It also permits us to study the changes in brain activity or better brain connectivity when people recover. This is a very old study where we observed that there's a recovery of thalamocortical interaction, communication, in patients after a vegetative state, unresponsive wakefulness, and now the possibility to implant electrodes. This is the work of Nicholas Schiff, Cornell, New York, helping patients with severe traumatic brain injury using deep brain stimulation of the thalamus. In our center, we've been emphasizing non-invasive neuromodulation using TDCS, that stands for transcranial direct current stimulation. We could put 2 electrodes, a very low current, 2 milliamps for 20 minutes, and we've shown in controlled clinical trials that about half of the people do show clinical improvements. So a number of new therapeutic possibilities there to challenge the old dogma that said, well, if you don't see recovery in the first months for cardiac arrest or first year for traumatic brain injury, no way these patients will show any change. We now know there's some hope for some of these patients, and neuroimaging is helping us to identify how we can better target these therapies and improve plasticity. And then there's big questions about what is it like to be in that condition? Should we continue care? Very challenging. The big question for me is that what is it like to be minimally conscious? Can these people experience pleasure? Should we continue life-sustaining treatment or not? Neurotechnology and brain-computer interfaces are permitting to give a voice to patients, and that's what we're working on. In the meantime, we asked locked-in syndrome patients. Remember, those with a brainstem lesion, they're completely conscious but paralyzed. They're tube-fed, they can't speak. We only have a small movement of the eye to have a yes or no answer. So I asked the question, how are you? You can't be more motor handicapped than that. And on this scale, from -5, the worst, to +5, the best, these were the results. Very surprising. +3, +4, maybe more than some people in the room here. So we should not judge a book on its cover. Very important to improve the trajectory of care, because we also showed that the patients with a very low quality of life had limited access to these technologies permitting them communication. And then, of course, some of them scored -4, wanted to die, very important in the whole discussion about euthanasia and end of life. Another study, and And I started with the challenge of saying meaningful things about pain, pain in animals. Here it's pain in humans with traumatic brain injury. By definition, they can't tell you, I have pain. But the neuroimaging can tell us what's going on. So we apply noxious stimulation. There's the whole pain matrix. You see it in healthy volunteers. People in minimally conscious state, to our surprise, activated nearly in an identical way that whole pain matrix. So we should systematically use painkillers in these people who recover from coma through unresponsive wakefulness, minimally conscious state minus, plus very big ethical, societal, and even legal consequences. As Stuart said, in addition to studying neuroplasticity in the brain damaged, we also look at modification of consciousness in hypnotic state. So this is something maybe you see used in theaters where someone is hypnotizing you. The reality is that it's a very useful tool. We can orient your attention and create this kind of bubble where you're absorbed, dissociated, and we've shown that it reduces pain perception. We now have over 20,000 patients who undergo surgery, such as removal of the turret or rhinoseptoplasty, so correction of the nasal septum, plastic surgery. Normally you have general anesthesia. This is the work of Marie-Lise Femonville, an anesthesiologist, who introduced this into the operating rooms, theater, and we published how these networks we can capture with neuroimaging change when you are in this condition of hypnosedation. And we also now work with a number of partners using immersive virtual reality, where you can again experience this thanks to new technologies. And we will see, I'm sure, more of this in the future. So this is complementary to, of course, the drugs we use. We have ways to kind of empower patients, because this is a form of auto-hypnosis. You're doing this yourself with just accompanying patients. And then there's a study of these experts of the mind, Matthieu Ricard, many other lamas. When I travel in the Himalayas in India, I always have this little device that permits me to capture what's going on when they are in these deep meditative states. And you see below, this is a visual representation of the activity. So when they're awake, non-meditation, and then they start their practice, and you see this switch, and they can keep that for very long periods of time. So meditation is just mental gymnastics. It's orienting your attention to one thing. There's different practices, just like sport, and depending on what you do, we see different neural signatures and the effect on the brain structure, cortical, and those thousands of billions of connections we call neuroplasticity. This is Matthieu Ricard and the MRI showing like the tree of those many billions connections. And studies have shown that if you and I, we start a meditation program like mindfulness-based stress reduction, we can also capture these changes, this neuroplasticity in, of course, non-Buddhist, and we can learn that and translate it to our reality. So I believe it's very challenging times. The study of consciousness now is a very active field. We're definitely not there yet when it comes to an explanatory theory. We need more people studying this. There's a couple of Nobel Prizes out there. Some say it's too complicated. I think naively as a physician, we should at least give it a try, because the implications that we've seen for people with disorders of consciousness are very real, and the past 2 decades have shown that we can translate that to better clinical care. So we work with neuroimaging to reduce the diagnostic uncertainty, predict better the outcome, develop new therapeutic tools such as neuromodulation, but also use robotics. You see here a center in Belgium where we show that these exoskeletons and these robots really can offer a better future for severely TBI patients. I think this was my message for this morning. I thank you very much. So as a physician, my challenge now is to empower patients and citizens next to the high-tech, highly specialized medicine to emphasize what we all can do. Meditation, hypnosis are just some examples, and the impact on neuroplasticity is now well documented. And so the big challenge is to use top science and machines making objective measures, but of course connect that to the subjective experience, the neurophenomenology of the person who is in the machine. And that is happening now, and I think it's very, very exciting times. And I wish you a great meeting here, and thank you very much for your attention.
Thank you, Stephen and Louis. Maybe one or two questions real quick while Claudia gets ready. Microphone.
Couple of questions, actually. So if we look at the current state of quantum computing, it may not be far away when some of these humanoid robots are powered by quantum computers, and they can simulate pretty much every human behavior that we can sort of respond in response to external stimuli. Now, some of the techniques or the direction that you are looking into in the consciousness, will you be able to tell whether those humanoid robots powered by quantum computers have consciousness?
As you said, these supercomputers, quantum or classical, they can pretend to have empathy, to understand us. It is very hard for us to differentiate, okay, is this coming from a real human or a robot? But that's about it. My view on this is that with the current state of affairs, there's more consciousness in a fruit fly than in the most sophisticated quantum computer. So I think the challenge really, because we live in this hyper-connected world where technology is really important, and we need to go where computers fail. They can't feel love. They can tell us what is good or wrong. You know, those things maybe we should give more attention also in the educational system. It's not about just learning kids about knowledge. Louis wants to be a basketball player. He wants to be a chess player. There's no way he's going to beat your robots. But little Louis can, first of all, make the decision. I want to do that. I have this passion. I feel the frustration when I miss. Your robots are not feeling anything, right? So they can just pretend, and I think that's going to stay for a while. And so the challenge for us is to, well, go there where computers fail, which is our emotional feelings and empathy, compassion, and then make the best of it. So,
yeah, I mean, then the next obvious question is, in the study of complex behavior of brain, neuroscience, what is consciousness? We are studying just the brain, or we are studying consciousness?
I think the short and honest answer is that we really don't know. How something material, like my brain, my favorite organ, produces what is so important to us, thoughts, perceptions, emotions, so we can make correlations. But a real explanatory theory, I think, we don't know. I think the past decades have been fascinating because we're doing a lot of research. Have we reduced our ignorance by 50%, 5%, 0.05%? We don't know what we don't know. So that's why all the young people here go for it. You know, looking at our internal universe is just incredible. And so quantum mechanics is just baffling, but it's still easy compared to the real challenging question, what is life, what is consciousness?
Okay, we're we're going to cut it off there and save time at the end for all three. Let's give Stephen and Louis a big round of applause. Moving right along, it's my great pleasure to introduce CLAUDIA PASSOS from the Center for Bioethics at NYU, who will speak on can we detect consciousness in newborn infants. CLAUDIA. You might want to hold this. Okay.
Okay, can you all hear me? Okay, thank you very much, Stuart. It's a pleasure to be here, and it's an honor to be in the Science of Consciousness celebrating the 30th anniversary of this conference. So, my talk is about newborn infants' consciousness, and you might think that Stephen and I coordinate our talks, but actually he did a wonderful job, introduced many of the concepts and ideas that I will use to think about infant consciousness. And also, I think I'm a philosopher and psychologist, so I have less interesting slides as him. So I think maybe bear with me. I think I'll try to make more sense of the evidence. Okay, so this project is part of a big, large project with a grant I have with Templeton Foundation that I try to understand what are the predictions that theories of consciousness might have in cases where we don't have verbal reports, okay? So the question that guides, and I will say less today about machines or less or nothing about machines and animals, and I'll focus about infants, and I'll focus less about theories and focus more about neuromarkers. So the question that will guide my talk is when does consciousness emerge in human development? So we know infants are awake, they cry, they have a sleep-awake cycle, they are attentive to stimulus in the environment, but are they conscious? And for this, I mean phenomenal consciousness. Are they phenomenally conscious? So the question is, are newborns conscious, perceiving, have experience of perceiving, feeling, or acting, okay? So we saw with Louis that he is capable to talk, to interact. We also saw that he is capable to respond to verbal commands. So Stephen asked him to raise his arm, and he's capable to understand and have a kind of behavior that is followed by understand the question and have a behavior that correspond to the question. But in the early stages, you don't have the same type of behavior. So infants, they might be capable to have some control in the mouth area and some control with the eye gaze, but they cannot follow any kind of command. So if asking them to raise their arms, they cannot raise their arms. So although we know that an infant, I don't know Louis' age, but maybe 7 years, 8 years, I don't know, 6 years old. So we know probably we're very confident that infants after 3 years old or 4 years old or 6 years old are conscious, but you're not as confident in the early stages, okay? So early stage raises this question of how can you know if the infant cannot give us any robust behavior indication that they are conscious, how can we know, okay? So currently, some methods that comes from the case of adults with absence of verbal reports have been using to try to detect consciousness in infants. So these markers were developed using evidence from first normal adults using verbal reports, and then they were applied in non-human animals and non-verbal neurological patients. So Stephen showed a lot of those markers that have been use in the case of neurological patients that don't have verbal report. And this method has been recently attempted to use these methods in the infant case. So, what we're trying to do today is to review this evidence in the case of infants and to review some specific markers that have been used so far to try to detect consciousness in early stages. So the 4 markers I will discuss is global violation detection and the association with the pre-300 marker, the functional network connectivity, attentional blink, and visual masking. So functional network connectivity, Stephen said a little bit, and I'll say how this marker has been used in the case of infants. So as just anticipating the conclusion of the talk, I'll try to show that the 3 first cases, global violation detection, I'll say in a moment what those markers, what means those type of markers. But the 3 first markers, global violation, function connectivity networks, and attentional blink, I think they make an interesting case for early emergence of consciousness. And backward visual masking will raise a challenge for the idea of early emergence of consciousness. So just before I present all the markers, I think one important piece of this puzzle is, although we are very confident that infants after 3, 4 years old are conscious, only if you hold a very extreme view, a kind of solipsistic view that you just know about your own conscious state. Most theories of consciousness and most theories would agree that infants are children at that stage are conscious. In the early stage, we don't have an agreement among theorists. So some theorists think that the consciousness emerged earlier, so probably a kind of sensorial consciousness. And some theorists think that consciousness emerged later in development and would require some type of cognitive processing, okay? So the debate nowadays goes around either some theories that will bet that consciousness emerged after birth or at least in the first 3 months, and some theories that say, okay, we need more robust cognitive architecture, so maybe consciousness emerged after 7 months or in the first year of life, okay? And I'll try to make the case that this evidence is compelling in favor of early emergency. And I will spend more time in the last paradigm because the backwards visual mask, because I think this paradigm raises a challenge for the idea of early emergence of consciousness, and I'll try to come with an interpretation that makes this paradigm more favorable to the view. Okay, so global violation detection. So this paradigm comes from studies with patients with, you cannot hear? Okay, okay. This paradigm comes from, I'm in between seeing my slides and seeing the microphone, but it's okay. I think now I find a good spot. So the local global paradigm, it's an auditory audible paradigm where there is an expected sound after a sequence of repeated sounds that our brain usually respond with a kind of novelty response when we hear a different sound after being habituated with a sequence of repeated sounds, okay? So to give you an idea how those trials are developed, we have what we call local oddball, that is, we have a sequence of 4 sounds and 1 sound that is deviant, the 5th sound, so it's like beep, 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 boop, or you have a global oddball where we have a set of sounds, a sequence of repeated sounds, and the last set of sounds is deviant in comparison, relative to the first, to the previous sequence of sounds. So to have an idea how you can construct this, these sequences is beep, 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 boop, beep, 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 boop, beep, 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 boop, beep, 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 beep. So the first three sequences, you have one deviant sound, and the last sequence of sounds, you have no deviant sound. So what evidence shows is we can perform or can learn the first sequence, the local audible paradigm, unconsciously. Okay, so our brain can respond to the learning of this first audible unconsciously, but global audible learning a sequence of sounds and learn that this sequence of sounds has a regularity that might be violated, needs conscious, the adult needs to be conscious to learn a sequence, this sequence, okay? So we call the first one local regularity and the second one global regularity. But and this paradigm was developed by Tristan Bickenstein and colleagues and was first applied in the case of patients with minimal conscious states to detect if the patients were capable or not to learn the global regularity, because this is the global regularity that would require consciousness. So what they show is that when you have this global violation detection, the brain responds with two types of response. You can either have what they call early mismatch negative response, that possibly indicate an unconscious response, or the brain can, and this first response is followed by a type of wave that is the P300 wave. That is a kind of a P300 complex that usually occurs at 300 milliseconds and after stimulus presentation. And usually in the literature, the P300 has been correlated to consciousness, to conscious state, or kind of a marker of consciousness. So they have been using this to say, okay, the global detection is, when you detect this global violation and the P300 marker appears, is because you're performing this consciously, okay? That's been a disagreement in the literature, whether this P300 actually is a marker of consciousness. That's been found that some non-conscious patients also display, or patients in comatose states also display the P300 marker. So you can say that maybe the P300 marker isolated might not be an indication, at least a strong indication, of learning those regularities consciously, okay? But the P300, together with the global detection, because the global detection requires, as a type of learning, requires to be a kind of perceptual representation that would be learned consciously. Those pieces putting together, we can say that there is a detection. We can use this mark as a detection of consciousness. And what is interesting is that they found this correlation in infants. So I studied with 3 months old baby and newborn infants at birth. And what they show first is that babies first show this two-level response, the early mismatch negative response, and also show the P300 response for local and global audibles. So they learn the local regularity, but they also can learn the global regularity. And the global regularity correlates with the P300 marker. And they also correlate this with high heart rate variability. So if you have heart acceleration, indicates the high heart rate variability. It's a proxy for being awake. Low heart rate variability is a proxy for being asleep. And they correlate this response, this brain response of the mismatch negativity and the P300 with heart acceleration, and they can show that when the baby or the infants are awake, more in a wakefulness state, this pre-300 you can see here in this graph. You can see that it correlates with the global violation detection, correlates with heart acceleration, and indicates that probably infants are learning this regularity consciously. Okay, so what is my assessment to this? I think these results provide significant evidence for consciousness in the first weeks of life. The evidence is not entirely conclusive, as one could argue, that these infants maybe are detecting global audible unconsciously, but actually we don't have any evidence, or at least elsewhere, that would be capable to learn to detect global audible unconsciously. So if there is no evidence for this, these results at least, I think, give us a strong initial case for conscious perception in newborn infants. Okay, the second marker comes from functional connectivity networks. So these networks were, Stephen presented us, is the external and the internal awareness, okay? So he nicely explained it, how those internal and external awareness are anticorrelated. There is some kind of anticorrelated patterns in the brain. So when you have an activation of an internal, the internal networks that we call the full mode network, when you have an increase of internal activity, we have a decrease of external activity. The external activity is correlated with attention and executive control, and the results find that there is some correlation between consciousness and these anticorrelated patterns, okay? So we might find activity in those networks that are not necessarily correlated to consciousness, but when you find those networks in activity with a sort of reciprocal activity, so one increase activity, when the inner awareness increase activity, the external awareness decrease activity, usually this correlates with consciousness. So from this, you can make some, or at least when you don't find, negatively, when you don't find these correlations, usually cases of patients under anesthesia or patients that are with disorders of consciousness. So from this, we can at least make a first case that those uncorrelated patterns of activity, at least it's a kind of correlations with conscious states. So they found this correlation at birth. They also found these correlations with infants that were born prematurely, but just at term equivalent age. That means when babies are born prematurely at 8 months of pregnancy, for instance, they don't find these correlations in the beginning, but when they achieve term equivalent age, they found this type of activity. What indicates at least that it's a kind of developmental benchmark that at birth those connectivities are starting reciprocating their activity. When one is increased, the other one is decreased. And you can see here the present, or in this graph, how if in some cases those functional connectivity are present before birth, but there is still not developing this reciprocal activity, okay? Okay, I think this is also, even if it's not evidence of consciousness, at least is evidence for capacity for consciousness, okay? So it means that at birth, this long range of connectivity that interconnect information in the entire brain is present at birth. Although we know that this is not, those functional connectivity networks are not necessarily sufficient for consciousness, because there are cases where the default mode network connectivity appears and without consciousness, but it's still, it's a strong, interesting evidence for at least the capacity for consciousness, okay? Okay, now attentional blink. Attentional blink, it's a type of a phenomenon that shows that if you focus your attention in one phenomenon, if your brain is attending one phenomenon, you're not capable to attend another phenomenon, okay? So, so there is some limitation of focus your attention for multiple successive targets, okay? And what you know about this phenomenon is for the attentional blink in fact to happen, the adult has to be consciously attending to the phenomenon, okay? So if you can show that infants also is susceptible to attentional blink, this is also an indication that they might be capable, or at least be attending these phenomena consciously, okay? So usually, so how the attentional blink phenomenon occurs, usually when the cognitive system attends to a first stimulus, it fails to attend to a second stimuli that is presently shortly after, with a variation of 200 million and 5 milliseconds after, okay? And what they show is infants are susceptible to this effect too. There is a nice experimental paradigm developed by Hockman and CDQ there. And they show they use faces to attract infants, because infants, as I said in the beginning, infants, they don't follow commands, so you cannot ask them to perceive or to be attentive to one stimulus. You have to use a stimulus that they can naturally be attracted to the stimulus. So they use face as a target faces, that we know that at birth we are born with the capacity to be attracted to faces. So they can use this to show that infants are attending to this stimulus. And what they show is that infants at 5 months, they are susceptible to the attentional blink phenomenon. And there is another nice study that show that this effect was found at 3 months age, okay? And they correlate this attentional blink effect with the P300 marker, that is a relevant marker for at least global workspace theory, that it seems correlated, at least there is some kind of evidence that might correlate with consciousness. It's true that the infants don't show the same P300 wave. They show a variant of this P300 wave, but this is the first, their response to this phenomenon is later, is at 400 milliseconds. So what shows that maybe this effect is already active, but is lower than we thought, okay? So one first assessment of this result is maybe the capacity for attending to some phenomenon consciousness might be already in place at 3 months, although we might need, the brain is still immature, so we might need more time. So this processing is low than it would be in an adult brain. Or so Dopriello and Emerson, they suggest that this is an indication for consciousness, the presence of attentional blink. I think that is at least suggestive, although I think there are limitations. I don't think you can completely rule out other possibilities. So, for instance, one possibility is whether this P300 wave that appears in those cases are actually a marker of consciousness. We can also discuss whether it would be possible to have attentional blink in the case of unconscious perception, although we still have some questions regarding this evidence. I think it's a first case, at least, is an indication that infants have at least the general profile of perception, of conscious perception, as in the case of adults. Okay, final evidence is from recurrent, some visual masking, and I'll discuss this in the case of recurrent processing theories. I'll spend more time in this, with this evidence because I think it raised some interesting problem for the case of early emergency of consciousness. Okay, so evidence suggests that recurrent processing is limited in young infants and raise challenge for the view that infants are conscious at the first month, okay? So although I will discuss this evidence in the case of recurrent processing theory, and I'll say in a moment about the theory, I think this evidence is a challenge for other theories. Any type of theory that require recurrent processing, or at least think that recurrent processing correlates with consciousness, might be in trouble with this kind of evidence, okay? So for instance, for IIT, consciousness requires a certain measure of integration information, which is 0 in pure feed-forward system. So the theory predicts that we need loop or recurrent loops for consciousness. Versions of global neural workspace theory also think that visual consciousness involves a global workspace in the prefrontal cortex, but also involves this consciousness is supported by recurrent processing, and recurrent processing theory that actually is the theory that that rely more in the idea of recurrent processing or recurrent loopings that are localized in visual sensory areas, okay? So I'll make the case more related to recurrent processing, but I just want to remind you all that some theories would be in trouble with this evidence too, okay? So what is the idea of recurrent processing theory? Visual processing, so this is from Victor Lam's paper of 2002 paper. So visual processes start with the feed-forward sweep processes from low areas to high areas, and localize recurrent processing. So this feedback loops processing from high areas to low areas starts at 100 milliseconds after the stimuli presentation. And for the theory, those feed-forward processes are unconscious, but the recurrent processing correlates with consciousness. So the information first travels in the brain, feed forward, and when the recurrent loops starts is when the stimulus become conscious. So this theory usually is tested with backward visual masking. So the idea is if you disrupt those recurrent loops, you disrupt consciousness, and there are lots of the fact that we are susceptible to those effects of backward visual mask is because recurrent loops are according to the theory, is necessary and sufficient for consciousness. Okay, so object substitution mask, just to give you an idea, is you show a stimulus, and right after the stimulus, you show 4 dots to disrupt the vision of the stimulus. And the idea is you first see the stimulus, so you have the information traveling in the brain, and then you show the 4 dots that disrupt the recurrent processing. And you want to disrupt the recurrent processing, you disrupt consciousness. And adults' brains are all susceptible to this kind of effect. So, so the theory used this visual backward masking to make sense of the idea that recurrent processing is necessary for consciousness. So Nakashima and colleagues developed a nice methodology to test this in infants. Again, This is the methodology paradigm. Again, they use visual, they use faces as a target. We know infants are attracted to faces, and they use the 4 dots you can see here in the paradigm, the 4 dots to disrupt their vision. And what they show is that infants at 7 months, they are susceptible to the fact, but early stages, they are not susceptible to the fact. So infants under 7 months, they continue seeing the faces, even if you try to disrupt the faces with the visual backward masking effect. Okay? And they also have another type of study with meta-contrast masking, but I will, it's the same type of paradigm that they show similar results earlier than under 7 months, no susceptibility. So it's a kind of immunity to those effects. And and after 7 months, they are susceptible to those effects. They also correlated these results with brain development, and the brain development shows that recurrent processing emerges later in development. So if the recurrent processing loops are not still developed, infants might not be susceptible to this. Okay, so this raised some problem for, at least for the theory, for recurrent processing theory. So here is one idea. So infants at 7 months have similar effects as adults. If infants earlier than 7 months might be seeing more than us, or if you follow the theory, if you think the theory is correct, infants under 7 months are not seeing at all, have no visual processing, okay? So in their interpretation is infants lack recurrent processing, and they might, if the theory is correct, they might lack visual consciousness, but if the theory is incorrect, they might be capable to see more than us, okay? Okay, so what are the predictions of the theory? What are the predictions we can make with these results? First, infants lack relevant recurrent processing, and therefore lack visual consciousness. Infant lacks, second prediction, infant lacks relevant recurrent processing, but they have visual consciousness, so the theory is wrong. Or a third interpretation, that the interpretation I will favor, infants have some recurrent processing, some different type, and some conscious vision that is consistent with immunity to object substitution mask, okay? So here is a way, my attempt to reconcile this finding with the theory. So a possible interpretation is there are 2 sorts of recurrent processing: early recurrent processing from higher to lower visual areas, which is required for visual consciousness, and a later recurrent processing from frontal to parietal areas to visual areas, which is the ones that are disrupted by backward visual masking. The later recurrent processing that is disrupted by visual masking is absent in infants. The early ones are unaffected by visual masking and are present in infants. So, and I use this to support the theory, but also support the idea that these recurrent processes, the early ones, are the ones that are supporting consciousness in infants. This interpretation can be backed up by early ideas of virtual lama. He has, in a paper with collaborators, that he says we have some recurrent processes that are interrupted in early stage that might go uninterrupted in visual backward masking. And I think you can use this to make a case that there are 2 type of recurrent processes. So this is a general suggestion. Object substitution mask disrupt the late ones processing, but not the early ones. Infants lack the late ones, the late recurrent process, but not the early ones, and the early ones are sufficient for consciousness. So this is a way to accommodate the theory, but also accommodate all the other theories I mentioned that also rely on the idea that consciousness might rely on recurrent process, that feed-forward visual processes can require recurrent processing for have a visual consciousness. I think I will skip it for matters of time. How much time I have? This is a yeah. I will skip fetal consciousness. I have 2 slides on fetal consciousness, but I will just say that the global audible paradigm, that is the first paradigm I discussed, there is an interesting finding that fetus at older than 35 weeks of gestation also display the same type of response, okay? And this, there are other interesting findings related to fetal consciousness, but I think this is the most robust one. We still have in relation to fetal consciousness, we still have the discussion whether they are actually deploying this capacity. They might be sedated in the womb with chemicals, and they might not be able to deploy this capacity, but it's an interesting finding that they display the same type of 2 responses we saw in the beginning, the mismatch negativity response, and the P300, the slow effect of the P300 reacting to the global regularity and correlates with high heart rate variability, okay? And they use this, they tested this in a different way. They use fetal magnetoencephalographic to detect those responses. Okay, so conclusion, my conclusion is conversion evidence from studies of cortical response to global audibles, function toward connectivity, attentional blink, tends to support the presence of consciousness in newborns and potentially in late-term fetus. In the first 2 cases, we still need some more evidence to confirm this idea. More conclusive evidence will require stronger neuromarkers of consciousness, which may require, in turn, better grounded theories of consciousness. I didn't talk that much about theories of consciousness, but I think for this, all those neuromarkers are discussions to give us a more stronger evidence. We have to correlate them with theories of consciousness. But still, it's a first attempt and shows something interesting. So we start with this idea that we might, we have this disagreement between theories that think that we need sensorial consciousness is more a matter of sensory phenomena, and theories that think that consciousness is more a matter of cognitive phenomenon. So in the sensory theories, we have recurrent processing theories and IIT. In the theories that might require cognitive phenomena, we have a global neural workspace and higher order theories. So usually there is this disagreement in the field, but I think we can make the sense of a certain conversion regarding early emergence of consciousness, given these findings, okay? So the audible paradigm and attention blink give a first attempt to show that maybe some cognitive processes that are relevant to consciousness might be in place in early stages. We didn't thought this in the past. In the past, we thought we develop first sensory areas and then you develop cognitive processing. So this is an attempt to show, surprisingly, that maybe some cognitive processes are already in place. And so this suggests that differences among theories of consciousness are consistent with progress on the question of infant consciousness. Thank you.
Thank you, Claudia. Let's take 1 or 2 questions, and I'm going to ask GINA to set up so we can move along and save time for all the speakers, including Louis at the end. Ingrid.
Thank you for your research and your talk. I'm just wondering, what about cases where children remember their birth experience or have very lucid memories of like when they were 3 or 6 months pregnant, the mother, of memories of things that happened in situations that the mother experienced, and the children have memories of that they'll talk about very clearly at the age of 2 or 3 when they start having good verbal conversations. And I think there are many cases of children who actually remember their birth experience that they relate later to their parents accurately.
Yeah, so this is an interesting case.
Here.
Okay, sorry. I think we still would need, memory, we can fabricate some memories, but it's still a first interesting finding that maybe some type of representations are at least some type of information at least are recorded in the beginning. So everything I said that might require some type of working memory in the beginning, I didn't say anything that would require episodic memory, like a memory or that we have from our autobiographic history, okay? So this, we would still need to test if the type of consciousness that those findings are suggesting actually correlate with this type of memory that might be required to remember a scene or remember a situation, okay? I'm talking about memory that stays very short, like remember a sequence of sounds. It's like seconds in your working memory. So we would need more, my response, we would need more study to correlate the type of memory you have in mind to the type of memory I was talking about.
Thank you.
Let's go there.
So I just want to thank you first for giving us such a wonderful presentation. And my question is, global violation detection assumes sound pattern recognition requires some level of consciousness. But my Siri here is able to detect my speech voice. What does it say about AIs who are capable to detect sound patterns? And also, people support this theory because no evidence are found in which an entity is able to detect an audible unconsciously. But maybe that's because an unconscious entity is unable to report.
I think I don't hear very much the question. You said something, can you just repeat again very briefly?
Oh, sorry, sure. So,
About the AI stuff?
So the global audible test, it assumes sound pattern recognition requires some level of consciousness. But the Siri on my iPhone, it can also recognize my speech voice. So what does this test say about the consciousness of AIs who are able to recognize sound patterns?
So we need to show that the AI would have the same type of sensory learning or perceptual learning we have, and that the oddball would apply to them. But I didn't say anything that would help us to extrapolate from one case to another case. That said, I'm not denying that in the future some type of computational functional network might give rise to consciousness for AI, but I don't think that we can extrapolate the capacity of this type of perceptual learning to the type of learning the machine learning has to recognize speech voice. I think it's a different type of learning that does not involve the same type of machinery we have, at least at this stage. I'm not saying anything. If this could be implemented in the future, maybe.
Thank you.
Yeah, thank you. Just briefly, don't you think that the consistency between the fetal oddball phenomenon and the newborns might show that they're instinctively able to respond to cyclical data, so that once the cycle is interrupted, that they can do that, but they haven't yet developed the ability to project this in time. So they don't have a consistent sense of time, but they're only capable of responding to cyclical events.
So what would be the conclusion if they cannot process in time?
Well, that it's part of the organic development is that at a certain stage they will be able to project events in time, and they will develop a sequential sense of events. But that as very young children, they're only responding to disruptions in cyclical events, like the mother's heartbeat.
I think the global audible shows that they can respond to sequence of the events in time. So the global audible, we have a sequence of repeated sounds that create a regularity. And the last sound is deviant to the previous sequence.
That's already a cycle, though, isn't it? It's a cyclical event.
Why you think it's a cyclic event?
Well, because you're going bang, 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 bang. And you're disrupting a cyclical phenomenon.
The last one is not bad. We have the last one is a sequence of equal repeated sounds. So they have to compare the last sound with the first ones to understand the regularity and understand that there is a novelty here.
Yeah, but it's still a disruption of a repeated rhythm.
Yeah. Okay, interesting point. I would have to think a little bit more about this.
So I don't think we're going to have time for a panel at the end, so let's take one more question over there.
Okay.
And let's thank Claudia.
Sorry.
Great,
Okay.
thanks so much for your talk. My question is about, yes? is about the durability or irreversibility of these markers. Have you ever followed infants over time, testing them every day or every week to see, do they display consciousness on one of these markers and then they have a bad night's sleep the next night and they don't display it, or they get a cold? Like, is there backsliding here?
Yeah, this is a very good question, because both studies I mentioned with the functional connectivity, they have a hard time. If you see the literature in this area, it's hard to make a very convergent inference of what's going on, because first they were testing infants in different conditions, they are using different methodology. The last study, that the one I showed, they tried to take into account this variation of different stages or different age, different moments, but also take account of different ways to measure those function connectivity and come with a nice attempt to make a more coherent result that would be across different studies. So it's a very, they have a large data set of infants that they tested. They couldn't do this, just one lab doing this. It's different across labs. And they come with some conversions of what we might make with this type of variation. Not just the variation of the infants diachronically, but variation about the type of methodology you assess the brain. And they come with a nice, I think their conclusion is interesting, because there is a sort of a conversion that they have this functional connectivity. In the other paradigms, it's very hard, because you have to test infants by infants, and you can have some variation. But it's still, I think the attempt to coordinate this with other types of behaviors and signal measures, like the acceleration of the heart, pupil size, gives you an indication of what type of state infants are at that moment they are tested.
Thank you.
Thank you, Claudia. Let's give her a great round of applause. Super talk. Our third speaker of the session is GINA Poe, who is the new incoming director of the UCLA Brain Research Institute. And we'll be hearing more about her work there in the future. And she will be speaking about detecting consciousness. GINA Poe.
Thanks so much. I think I got this. Yeah, thanks. Hello, thanks so much for this invitation. I was last at this conference in 1998 here in Tucson, and it's a pleasure to return. Back then, microtubules were first introduced to me as possibly having consciousness, and it actually made a lot of sense. So I really was glad to be introduced to the whole field of consciousness back then. Since then I've been studying sleep. So thanks to my lab, I want to give thanks to my lab for hanging in with me through the pandemic. We had lab meetings every day for a long while, but UCLA was shut down for a long time. So it used to be that we thought that only birds and mammals had sleep, and even 2 states of sleep, which are non-REM, deep slow wave sleep, as well as rapid eye movement sleep. But it's just because we didn't look. Once we started looking at other kinds of animals, we've realized that even dragon lizards have rapid eye movement sleep as well as non-REM sleep. That Drosophila, if you look closely enough, even have a twitching state of sleep that's akin to the twitches that we do in rapid eye movement sleep. And then even if you look at the jellyfish, you can see that first of all it sleeps, and then it even seems to have 2 states of sleep. And a lot more research needs to be done on this. The water bear, we don't know. It looks like it's asleep, so I put the picture in there. But if you think that all of these animals sleep, you might also go on the opposite side of that, which is that they're all conscious as well when they're not sleeping. I know that that's probably not the way you think of it, but it's the way I think of it. So across phylogeny, all animals sleep, from whales to worms. And again, it used to be that people thought, oh, worms don't sleep, but that's because they only studied them under the bright lights of the microscope. And of course, the worms were trying to get down into the dirt, and so they were not sleeping at that time. So here's there's a phylogenetic tree in the sea where the Cassiopeia jellyfish is there at the top. Until just 2017, we didn't know that they slept. But at Caltech, they did the study and found that jellyfish do sleep too. So here is a waking jellyfish pulsing at faster rates, and a sleeping jellyfish pulsing at slower rates. As Deepak Chopra talked to us about this morning, it all starts with breathing. And so jellyfish also slow their rates of respiration unless we sleep deprive them, as we did to this one to the right, by giving them a jet stream of water. And if you do that enough, they will homeostatically regulate and get more sleep, more naps the next day if you do that a lot to them at night. So it's super cool. Here's the respiration rate of the jellyfish during the day at top and at night at the bottom. And you can see that even though the respiration rate slows at night, you can also see periods of time when it stops altogether. And if you were just watching this recording going along, if you're watching the jellyfish, you'd say, oh, the poor thing just died, right? Because it's not moving, but it's not even breathing. But in fact, you know, you can see it picks it up later. And in fact, sleep has been likened to death in many, many you know, great works of art throughout the ages. And it could be that, you know, you see this echidna on the road and you say, oh, thing is dead, you know. But it's just sleeping. The echidna is actually a really interesting animal because it seems to only have one state of sleep, but that state of sleep seems to be a mixture of REM and non-REM, and it has lots of atonia like this. The brainstem is active in a way that suggests it's in REM sleep all the time, but also it's slow waves that you see in the cortex. Looks like it's in slow wave sleep all the time. So there was some debate. Here's a spider here's a baby spider. I really am afraid of spiders, so these videos creep me out. But its legs are completely curled in, but if you look at the eyes, you will see that even though it's not dead, the legs are jerking once in a while, and the eyes are moving. And it does this periodically all night long. Goes through periods of quiet where it's really just not moving. This one's suspended from a web, and then periods of time, brief periods of time, when it is moving quite a bit. And when its legs curled in, that's when it's atonic, which is the same thing that happens when it's dead. The legs are curled in. The video to the right. It didn't show, but oh no, it's showing right now. You can see, I mean to the left. Oh no, to the right. It shows that there's an adult spider also jerking once in a while, and it comes and goes just like in the jellyfish and just like in us. All right, here's another animal that if you saw what it was doing, you would think that it was dead. What it does first is it swims. This is a seal, and a seal that cannot sleep one hemisphere at a time, and yet it spends weeks at a time out in the ocean fishing. And people assumed because it doesn't have unihemispheric sleep and it's out there and needs to stay at the surface to breathe, that it wasn't sleeping for a couple of weeks at a time. And then when it went back to land, it actually didn't make up any sleep. So people thought, well, you know, this sleep is not necessary in this animal. It's fine without it. But when they actually put a helmet on this animal and recorded its brain activity, what they found is that what it does to adapt and to sleep while it's out there in the ocean is it does a 23-minute dive where it swims down to beneath a depth where sharks and killer whales would predate upon it. So it's safe down there in those deep depths, but also it continues to sink once it's down there because of the pressure. And it goes to sleep. And when it's sleeping, then it even goes into REM sleep. Let's see, I think I have in the next one. And REM sleep is atonic, so it has absolutely no muscle control, and it starts spiraling down, down, down until it hits the ocean floor. If you were in a submarine, you'd say, oh, look at that poor thing. You know, it hit its head, it's dead. So here's a video. It's actually not a video, it's an animation. They didn't have a camera on this animal the whole time, but they reproduced from all the data that they had, this showing how it swims down to a depth where it can, it's very deep at this point. And then now you can see in the EEG trace going across, it's going to sleep. The bright lines at the bottom show that there are slow waves going on in this seal's brain, and it's beautiful slow wave sleep. And continues upside down. He's just totally relaxed until he goes into rapid eye movement sleep when he has atonia, and that's when any kind of asymmetry in its fins would begin it spiraling down, 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 down. And I don't know, it makes me anxious to watch this because I can't hold my breath longer than about 60 seconds, but these guys can really, really do it. And in fact, even when they hit the ocean floor, or in the case when they're too deep and there is no ocean floor anywhere nearby, they wake up after 7 or 8 minutes, they start swimming up, but they even sleep on the glide up as well. So they swim and glide and swim and glide. So it's not like they're really that hungry for oxygen. It's an amazing adaptation, showing you really just how important sleep is and all the functions of sleep. So here's a guy's swimming back to the surface. Whales also sleep unihemispherically, just like dolphins, but if you come across a pod of whales sleeping, you might find something like this. You're going to see in a moment. This one's obviously awake, responding to the boat that just touched it. But look at all these other whales that are sleeping straight up and down in the water. And you'd look at that and say, oh my gosh, aliens have taken over. You never see a whale in this position, but this is when they're in REM sleep, when their bodies are completely neutral. There's no muscle tone at all. And that's the position the fat pads in their head brings them to, is straight up and down. And they sleep like this in a pod, and they do this every single day all over the world. It's a really beautiful study done by people. So this is the position. They start, and then they can flip over, and they can do this for 20 minutes or more at a time. All right, all over the world. Okay, so what is sleep, really? And on the converse side, what is consciousness? Sleep is a behavioral state. This is the long-standing definition of it. It's homeostatically regulated. If you don't get enough of it, you'll get more. There's characteristic posture, and there's reduced responsiveness to the outside world, and increased arousal threshold, the same two sides of the same coin. So you don't really respond to people talking to you or to people doing boop, 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 boop to you either. And that it's rapidly reversible to distinguish it from coma. But we know we can sleep in all kinds of situations if this is sort of an emphasis that it's homeostatically regulated when we really, really need it. And if we don't get it all night long, we will wedge ourselves into uncharacteristic postures and still get the sleep that we need. If we don't get it, we die. Okay, so the other things to characterize sleep are the electrophysiology, the things that are happening in our brain, and the neurochemical milieu. And in fact, there's a lot of ways to characterize sleep, and opposite, a lot of ways to characterize consciousness. So first quiz question is this man asleep? What do you think? Probably? What else do you think? Anybody else? Yes? Who says no? Why? Yeah, okay. I say no also. Why does anyone say no? He's not asleep. He's smiling. I don't know. That's possible. Certainly infants often smile. It's in REM sleep. He could be in REM sleep. He looks not quite relaxed enough to me. But so you can tell sleep by their posture, respiration. Again, breathing is first. If you walk into your kid's bedroom and they're trying to pretend to be asleep, one of the things you can do is just count their breaths. They cannot breathe as slowly as they do when they're actually asleep. So motionlessness, slow rolling eyes is something also when you first fall asleep. Relaxed muscles. Your blood flow reduces a lot in your brain when you're going into non-REM sleep, and then it increases to incredible levels when you're in rapid eye movement sleep, more so than even wakefulness. Your brain and body temperature, heart rate variability, penile tumescence, that's a good marker for REM sleep. And if you could measure it more easily, clitoral tumescence as well happens in REM sleep. Then if you're looking at the EEG, you can look at local field potentials with depth electrodes. You could look at single cell activity, all of which we've done, calcium activity in influx, and you could look at fMRI. And all of these things will tell you the difference between different consciousness states. And you can look neurochemically as well. So here's my grandson. He was born 6 months ago. I don't see the videos playing. Hang on. I will not let you suffer without the video. He's in my lap, and he's in rapid eye movement sleep. He's in active sleep. He, at this point, was only a month old. And it was easy to tell the difference between sleep and wakefulness. Although their active sleep is so active, a lot of parents think that they're actually awake and will try and interact with them. Their eyes aren't always closed, for example. Their eyes are rapidly moving, and people think that they're awake. But this child is asleep, trust me. Very much asleep. Okay, so let's go back a moment. So we go from wakefulness to non-REM stage 1 and 2, and then to deep slow wave sleep, which is under the highlight right here. Infants get more and more of this as they develop, but they have a lot of the REM sleep period. From deep slow wave sleep, we go into the non-REM stage 2 again, where we have beautiful sleep spindles. And I'm going to talk about these in terms of whether or not sleep spindles might represent a kind of at least internal consciousness. And then we go into rapid eye movement sleep with very active rapid eye movements, very vivid and long description of dreams. And in the hippocampus, our learning and memory structure, we have this beautiful thing called theta rhythm, which is 5 to 10 hertz, beautiful rhythm that can sometimes be reflected in the cortex as well. And that's really important for learning and memory. Actually, theta is something that people doing transcendental meditation get into that theta state very nicely. So we don't know why, but we do know the function of theta for REM sleep. All right, so this is how our sleep progresses across our lifetime. It's nonlinear on the bottom, but you can see in the first weeks of life, we have a heck of a lot of REM sleep. And in fact, if you project back into the womb, REM sleep takes up even more of the time. There are periods of wakefulness where infants will respond. That starts about 7 months gestational age when the brain is developing. The neurons are going to where they go, and our cortex can respond to sounds coming in and all of that. So 7 or 8 months gestation, that happens. Okay, so here are the neurotransmitters. You can see in each of the states, waking is a column to the left, and then slow wave sleep, the one thing that really changes is the amount of acetylcholine. Acetylcholine is in blue at the top, and the amount of acetylcholine drops with unihemispheric sleep, and it's really due to the loss of acetylcholine. It's also called the searchlight of consciousness. George Masur, which may be here in the audience today, or maybe not, has done a lot of work on acetylcholine and its relationship to consciousness, but as have tens of other people. And then during non-REM stage 2 with those interesting sleep spindles, which you can see in the light blue there, those sleep spindles are really dependent on all of these neurotransmitters being absent. So it's kind of the opposite of waking. Wakefulness has high levels of acetylcholine, norepinephrine, serotonin. That sleep spindle state is absence of all of those things. However, there are bursts of them that end the spindle, so interesting. And then REM sleep, where the big, beautiful theta in the hippocampus, which you can also get, hopefully, in your brains right now when you're learning. It's present in REM sleep, which is probably one of the reasons why people think that the dream state of sleep, which dreams can happen in lots of different states, but we'll talk about that why. But in that rapid and vivid dream state of sleep, why it's probably thought to be conscious, because there's so much acetylcholine in the brain. But as you can see, norepinephrine and serotonin are down to nothing. And so REM sleep is really actually kind of the opposite stage of slow wave sleep, where you have no acetylcholine, but norepinephrine and serotonin. So each of these states are as different from one another as can be, at least neurochemically, and also in terms of brain activity and electrophysiology. So the fact that we have 3 major states of sleep, I just have wakefulness as a a monolithic structure, but we all know, if you look around the room, we're not in all the same state of wakefulness. Some of us are sleepy and dozing, which is fine. All right, so here's the locus coeruleus, which provides norepinephrine to the brain, and here's how active it is during wakefulness. You can see the locus coeruleus. These are individual spikes of the locus coeruleus, which is deep in the brainstem. Locus coeruleus means blue spot because it shows up as blue, and you can see it firing, hopefully a lot right now as you learn. It's responsive, really responds to those oddball tasks. When something unexpected or surprising happens, the locus coeruleus is the first thing to notice it and alerts the brain, hey, something's happening here. What has changed? If there were a sudden big sound outside, we would all turn your attention from me to what might be going on outside, and that's the locus coeruleus responsible for that. If you inhibit the locus coeruleus, you won't do that. It slows down in slow wave sleep. In that transition to REM sleep with sleep spindles, it goes to almost nothing to allow those sleep spindles to happen. And then in REM sleep, there are long periods of time when the locus coeruleus is not firing. As soon as we wake up from it, the locus coeruleus fires again. So here's how it fires during sleep spindles. So sleep spindles are something that emerges quite early in infants, and it's thought to coordinate the connection between our brains and our bodies, because anyway, there's a lot of really cool research that shows that before our motor cortex even develops and can control our body, sleep spindles are sending excitatory information both directions and helps them learn to coordinate so that when we're awake, we can coordinate those things. Anyway, the locus coeruleus is off before each sleep spindle. And one of the things that a silence of the locus coeruleus can do uniquely, and the only time you can do it is when your locus coeruleus is silent, is depotentiate or weaken connections between synapses. When we're born, our brains and our spinal cords, or before we're born, they're overly connected. And in fact, experience gives us a chance to strengthen some connections and completely eliminate others. So for example, when we're learning who our mothers are, if you're a chick at 17 hours after eclosure, that's what it's called, when you get out of the egg. And it's a maximum time you can learn about who to follow for the rest of your life, or at least the rest of your, what is it called when a bird is really young? What's that? Chick. Yeah, right. Okay, so they don't follow, but also the imprinting on their parent is also an imprinting about who their mate is going to be in the future. So if you have a duck imprint on you, because you watch out, because that duck, when it grows up, will try to mate with people. Not a good thing. Anyway, that imprinting is really important, and what you're doing when you're imprinting is you're learning not only the features of who your parent is, but also all the features that are not your parent. So if you have a broom, and the broom is the only thing it can imprint on, it will imprint on the features of that broom receding, going away. So, and that's because in sleep, right after that imprinting event, there's a lot of pruning going on. All the features that could have been its parent but aren't are pruned away, and that's because the locus coeruleus is silent during these stages. All right, so it's deep in the brainstem. It's in all animals have a locus coeruleus of sorts. In insects, it's octopamine instead of norepinephrine, but it does the same thing. All right, so one other thing I wanted to show you here is that the locus coeruleus during slow wave sleep, and here are the big slow waves of slow wave sleep, you can see that it's silent between slow waves, but at the most silent portion of the slow wave, at the depths of each slow wave, which some think are the most unconscious of normal states, when your cortex is most silent, your locus coeruleus wakes it up again and brings it back to the peak. It fires at the depths of that trough of slow wave, and then allows all the cortical neurons, or a good majority of them, to fire at the peaks of each slow oscillation. And each slow oscillation is, happens once a second or once every 4 seconds, something like that. So you can see it's rapid. If you want to call locus coeruleus activity something to do with attention, like acetylcholine is, then it might be your unconscious state is really brief in slow wave sleep. All right, so here's the locus coeruleus firing rate. One of the things the locus coeruleus responds to is stress. So if you stress an animal out, here's some rats that we put into binding so they feel like they're in the claws of an eagle, although they're perfectly safe, but they don't like it. If we put them into a tank and have them swim around, they can swim just perfectly fine, but they're looking for a way out. That's stressful. If you put them into a bell jar with ether, that's a direct stressor of the whole stress axis in their brain. And then if you stress them out by isolation, all of these stressors strongly activate the locus coeruleus. And so you can see during wakefulness, after this stressor, the locus coeruleus is firing a lot faster than it does during wakefulness before. And then during REM sleep, when the locus coeruleus is supposed to be silent, sometimes we find that the locus coeruleus continues to fire and reactivates at quite rapid rates. And some research that we're doing in the lab and other people are doing are showing that people with post-traumatic stress disorder, their locus coeruleus never shuts off in sleep, and that it just keeps firing and keeps re-strengthening those traumatic memories instead of allowing you to depotentiate some of them, especially in light of new information like safety information. Locus coeruleus has been recorded for 40 years, 50 years, and no one has recorded from locus coeruleus in a female, so we're doing it. And what we're finding is that at some phases of the hormonal cycle, the locus coeruleus also doesn't shut off in REM sleep. See the red bar in REM sleep? That's female rats at low hormonal phases with low estrogen. The locus coeruleus also doesn't shut off, which might explain a lot of things, including why women are 2 to 4 times more likely to get post-traumatic stress disorder after a trauma, why women have more insomnia at some phases of their menstrual cycle, and we find the same thing with rats. Okay, so the next portion we're going to talk about, let me see, we have a couple more minutes. Is consciousness coherent? Is sleep coherent? Is consciousness coherent? So here's the locus coeruleus and how it projects all over the brain. But in fact, this representation of the locus coeruleus is not up to date. What we know now is that there are modules of cells that project to different areas. So some locus coeruleus cells project to the prefrontal cortex and the hippocampus, and others to the motor cortex and other areas. And so really there can be a modularity of alertness. And the same is also true in the cholinergic acetylcholine basal forebrain. This searchlight of consciousness, acetylcholine, is also not monolithic. So this is unit discharge measured by Barbara Jones's lab. You can see PS, which is paradoxical sleep, at the far right, is the same thing as REM sleep or active sleep. And then active waking is at the far left. And you can see it's acetylcholine cells are pretty active during active waking as well. But in between, especially during non-REM slow wave sleep, you have very little amounts of acetylcholine because the cholinergic cells are off. However, if you measure from every single one of these cholinergic cells, you'll get actually a different story. I won't go through this. This is just the rapid firing rate, for example, during REM sleep, paradoxical sleep, and the slow firing rate during slow wave sleep. But here is an image of the cholinergic cells in the basal forebrain, showing that the different colors of cells are different groupings of cells that project all to the same areas of the brain. And you can see that there are modules. And that makes sense because the searchlight of attention is not like when you're awake, you're attending to everything all at once, all the time. You are, attending to some things like this might sound of my voice or the screen, and not to how your body feels right now in your seat. So that's a searchlight of attention. So this is really cool study of unihemispherically sleeping fur seals. And what she showed is that when they're out at sea, other people have shown this as well, that they can sleep one hemisphere at a time. And what she's found is that the hemisphere that is asleep is the hemisphere that has the least acetylcholine. So down there at the bottom right, you can see a graph that shows that acetylcholine is high in quiet wakefulness when both sides of the hemisphere are awake. And it's low in both sides on the far left there. Bilateral slow wave sleep is low on both sides, but in left asymmetric slow wave sleep, acetylcholine is high in the right hemisphere. And similarly, when it switches, acetylcholine goes low in the other hemisphere. So it's pretty cool to be able to record from cholinergic cells, the right ones at the right time, and be able to tell which side of the brain is asleep and which side of the brain is awake. So normally we go from wakefulness to non-REM sleep, stage 2, and slow wave sleep, to REM sleep, and back and forth. This is how we think about sleep until we wake up, this sleep cycles. But is this really the way we sleep? And the answer is probably not. When we are sleep deprived, we are much more likely to have dissociated states where features from different sleep states and even features of wakefulness all mesh together, and you get sleep disorders like sleep terrors, where you're vocalizing emotions because your emotional system is highly active in REM sleep, but if it's crossed with non-REM sleep where you don't have atonia, you can actually vocalize those emotions. You have sleep paralysis where you have atonia of REM sleep, but conscious wakefulness. It's a terrifying time unless you realize that it's just a temporary dissociated state. Just go back to sleep and you'll probably wake up fine the next time. I don't know how many of you have ever had sleep paralysis. Yeah, it's a fairly common occurrence, at least once in your life, 2 or 3 times, especially when you're young and you have really high homeostatic need for sleep and often don't get it when you need it. You'll have more of these dissociated states. Confusional arousals, I think all of us have had those before too. Phone rings in the middle of the night and we have a conversation that doesn't make much sense. Sleepwalking and talking. and REM behavior disorder, where we're actually acting out our dreams. So these things are disorders. However, they all happen normally once in a while. My neighbor in Ann Arbor, she used to take Ambien once in a while, and whenever she did, she would wake up with a stack of pancakes cooked that she didn't remember cooking. So you can really do a lot of behaviors when you are unconscious and unaware. And how is that possible? It's really due to, I think, the modularity of these wakefulness promoting systems. And so you're not all awake all the time. Right. Okay, here's a, oops, let's go back. Here's a dog exhibiting a REM behavior disorder. Those who, I didn't take this video, but dog asleep, you know, it's twitching. I don't know if you've ever seen your dog or cat twitching in sleep. People do the same thing, but this one goes a little farther. And you can see that it's probably dreaming about running away and maybe fighting, and it's completely unaware of the walls around it. Yeah. So if you simply try to characterize consciousness or unconsciousness by behavior, you wouldn't do very well. You really need a variety of things. So we first noticed that rats could actually have two different states of in their brain at the same time when we had depth electrodes in their hippocampus and cortical electrodes up at the surface. And what we found is that we noticed, just kind of, that's weird, is that sometimes the hippocampus would go into REM sleep long before the cortex would. So at the top you can see the theta, which is that band that kind of appears halfway through and goes, that's a theta band. That's characteristic of REM, occurring in the hippocampus long before you get the desynchronized activity in the cortex, which you can see happens about halfway through. And so we analyzed this and found that in truth, it's probably a really useful state to actually have dissociated states. And it's some pretty interesting things are happening. One of my graduate students is seeing whether or not these dissociated states are necessary for consolidating our memories, and it seems to be the case. And then Raquel Guthrie, a student in my laboratory, looked in humans to see if this was true as well, if you could have the same thing. So these are people implanted with depth electrodes, and we found the same thing happens between the hippocampus and cortex in humans normally. This is in every human that we recorded from. Of course, these are people with depth electrodes, so you could say that they're not normal, but each one of them has a different, type of epilepsy and a different drug. And so what we found is that it's just really consistent that the hippocampus in red can go into sleep sooner than the cortex does. And it might be why we don't remember the last couple of minutes of wakefulness before sleep onset. And all through the night, the hippocampus can be in a different state than the cortex. And this is sort of a state transitions graph. But about on the left-hand side, you can see that about a third of the night, on average, our cortex and hippocampus are in different states. This has been replicated since we published this 2 years ago in another study, which went into even greater depth of analysis. But yeah, a third of the time on a normal night, our hippocampus and cortex can be in completely different states at the same time, and there might be a real interesting use for this. So I might have mentioned, maybe not, that the hippocampus, that the brain in REM sleep looks a lot like the brain in wakefulness. And so really, it's hard to tell whether this hippocampus is in REM sleep sometimes when the cortex is not, or if the hippocampus is awake when the cortex is not. And if the hippocampus is awake and able to record new memories, it might be one reason why we have something called sleep state misperception, where the cortex looks like it's, the sleep researchers say, hey, listen, you were asleep all night, and the person says, no, I wasn't. I was awake all night. I remember everything. And it might be just because the hippocampus was awake, or at least recording memories. So, yeah, in fact, this was analysis was done on 8 people. We actually analyzed 12 people, but several of them never had concordant sleep in both the hippocampus and cortex at the same time. So we didn't include them. And these states can occur, this is the duration, the bout length of these discordant states. On the far right side, the 2 columns on the far right side shows how long an epoch of the discordant state can happen. And so when the hippocampus, the first one is in non-REM stage 2 and the cortex is awake, that can happen for 25 minutes or longer and so forth. So there are long periods of time. So to detect consciousness, we really have to know where to look. What are we asking is conscious and what is unconscious? Where in the brain that is and what really we should look for. So with that, I'll just thank the people who contributed to the research that I showed you today, the people from my laboratory and my whole lab, and say thank you for your attention. And I'm ready for questions.
Thank you very much, Gina. Questions?
Thank you. You mentioned at the beginning, you seem to think that jellyfish, for example, because they can sleep, therefore they're conscious. But I don't know if I saw any evidence for that in your talk.
Right.
What makes you think that?
Yeah. Yeah, well, the first jellyfish that was thought to sleep was the box jellyfish, which has eyes and hunts for its prey. It has eyes and hunts for its prey, and it was found that it does sleep all night long. That one is probably easier because it's responding to its environment in the way that it is, you know, you can see it looking at prey and hunting for it. This Cassiopeia doesn't have eyes, and it doesn't have a central nervous system, but it has a peripheral nervous system, a distributed nervous system, and as you can see from the jet stream, it does respond to its environment, and it has reduced responsiveness during sleep, and then when you stimulate it, it will have escape behaviors, and it will look for the bottom and try to get back to sleep as soon as it can. It's a great question, and I'm not prepared to answer it, but I think that anything that sleeps has another state, and so that's the state of consciousness, I would say. Yeah.
Dante.
Yeah, thank you. Dante Loretta, University of Arizona. I was going to ask another jellyfish question.
Great.
What do you think that means for the evolution of consciousness? Do you think, because the jellyfish don't have a brain, right? They have a neural net and maybe a ring right around their mouth. You talked about the one with the photoreceptor, which we think is a relatively recent evolutionary adaptation compared to the ancient jellyfish. Mm-hmm. And as a follow-on, is anybody going even farther to the sponges, which don't really have neurons but are showing the beginnings of neurotransmitters, and maybe even to the protists, where we see the cytoskeleton showing up and really pushing towards what Stuart has been advocating for a long time, that it's the tubulin, which is characteristic of the eukaryotic cell, that might be the root of all of this.
Right. You know, the emergent property of bacteria, that when they emit enough of a toxin, when there are enough of them emitting a toxin at the same time, they all say, okay, this is the time, and they just all emit that toxin. It becomes very, very, I think that is, you know, you can't call that, I don't know. I think the microtubule hypothesis makes some sense. If you've ever seen a single neuron migrating in the brain to where it goes in the fetal stage, you see this neuron making decisions. You know, it's sending out Philopodia and saying, nah, and then sending it out over here, and then maybe going a little, no, and then it'll go up. And it looks like a snail going to where it's going to go, and it's making decisions. You know, I think it's, I don't know. I might be on the Stuart's end of the idea of consciousness.
I didn't know she was going to say that before I invited her.
Didn't.
Hi, Gina. This is Tapas from Bangalore. Is there a possibility that the short-term memory that perhaps we accumulate in the hippocampus during the day is uploaded to a long-term memory during this REM sleep, And of course, we know that so far long-term memory is not in the brain, so that's a different thing altogether. But is there a possibility?
Yeah, that's what most of my research for the past 25 years has been on, about the uploading of memories and consolidating from the hippocampus to the cortex. And it happens during those sleep spindles, where there's kind of unique connectivity, and the cortex is uniquely listening to the hippocampus. And then during REM sleep, I'll just give you a long story short, it seems to be the cortex and hippocampus are most of the time sort of not talking to each other, except in these dissociated states.
Yes.
And so, and what they're doing independently is cleaning up after the process of consolidation. They are trimming away unused, no longer necessary synapses, so we don't carry them around all the time. And so the cortex and they're strengthening cortical connections, building schema. There's so much activity during REM sleep, which could actually support long-term potentiation.
Thank you. Maybe I can talk to you later.
Okay, great. Yeah.
Okay, let's have 2 more questions. Please be brief.
This will be brief. A syndrome which you might be able to explain. Over the years, depressing dreams that come late at night just before waking, one cannot remember them. The depression goes away when one gets up and eats, goes to the bathroom and so forth. Is there some explanation for depressing dreams recurring, not every night, but late at night just before waking?
Huh. That's a good one. That's not a brief question. But yeah, the fact that we don't remember our dreams, I know there are people in the audience here today who would say that's a really good thing most of the time. And it's probably due to the state of the hippocampus. And working memory is working fine when we're dreaming, but writing from working memory to long-term memory is probably not happening most of the time for most people. The emotional system is very, very active during REM sleep, and sometimes there's a hangover effect of that emotional activation. I know, I've talked to many people who dream that their spouse is cheating on them, and they're mad at them for a week, even though they know it's a dream, because that's something you could have done. And the emotions are so very strong. Anyway, we could talk more about this in the next days. Thank you so much for the question.
Last question.
Thank you, Gina, for your great work. It's amazing what all you've done. And I'm just curious about, during our learning process, during the waking time, we're doing a lot of repetitive work. And I'm just wondering if the sleep cycles going from slow wave sleep to theta during the night, through all the different sleep cycles, is sort of a repetition of what's going on during our waking stage.
The cycling of sleep, repeating what we did during waking. I don't know the answer to that. I know there is some research on an ultradian rhythm that happens all along. Infants seem to show it more than adults do, but maybe that is just masked in us because we're, so in our heads. But yeah, that's a great question. I don't know. I don't know the answer to that.
Great. Let's thank Gina and all the speakers, including Louis. I'm sorry.